advance in medical laboratory sciences and masters also in medical laboratory sciences. Peter is currently working at Kenyatta National Hospital at the Department of Laboratory Medicine, where he is the head, he's the HOD of clinical chemistry. So Peter is here to give us latest advancements, best practices, and clinical roles in medical diagnostics, in diabetes care, and glucose monitoring. So I'd like to take this opportunity to welcome Peter to take it up from here. He will do his presentation, and kindly, while he's doing his presentation, I will request you that you put up your questions, your concerns, and your contribution on the chat. And when Peter will be done, we'll give him an opportunity to react to those questions and to those concerns and even your contributions. So members, I would like us to welcome Peter by claps, by giving him his flowers, and there are emojis there. So kindly welcome Peter. Welcome Peter to the floor. Peter, I would like to welcome you.
Thank you.
Take
Thank
up
you, Nelly.
Mike.
Good afternoon,
Thank you.
Nelly.
Good afternoon, Peter.
I hope you can hear me loud and clear.
Loud and clear, Peter. Karibu.
Thank you. Thank you so much. And thank you, Nelly, for the kind words and the kind introduction for this afternoon's discussion or webinar that we hold and try to share a few insights that we experience in our day-to-day activities. So once again, I wish to thank the LMSK, the Laboratory Medicine Society of Kenya, for this honor to invite me to do this this talk this afternoon. So members, as already mentioned, I'm going to be giving a talk on laboratory insights on glycemic monitoring. And I think glycemia is simple and complex in the same breath because the kind of things that are critical when you measure a value and give a value. It determines on what is done next to a patient or a person who's coming into the hospital. So what do I expect to cover this afternoon? I expect to take you through the overview of glycemic control, the general overview, why it is important for us to understand the dynamics and why it is a critical thing to do in glycemic control. And of course, we'll have to define glycemia and look at the homeostasis of glycemia in normal physiology. Then we will mention the methods that we use, the tools that we have as the laboratory professionals in monitoring glycemia and our role. So we'll cover a number of them. And then under these, we will look at recommendations that are published on the various aspects of monitoring glycemia, on the methods of monitoring glycemia. So that is the kind of what I will take this discussion this afternoon. In the next few minutes, we'll be able to discuss this. But just to start us off, when I was preparing for this talk, I just asked my friend Copilot to tell me what glycemia is, and I quote what exactly Copilot answered. So Copilot said glycemia refers to the concentration of glucose in bracket sugar in blood, a critical measure of the body's energy balance and metabolic health. It is usually expressed in milligrams per deciliter or millimoles per liter, depending on the region. And I felt that Copilot was very broad enough to cover quite a number of things in his definition of what glycemia is. And he was very cautious to put glucose and sugar in brackets so that if I'm a lay person, I would understand what glycemia is. And what it made me interesting in this is how Copilot was able to talk about why we measure glycemia, because we want to see the body's energy balance and metabolic health. And if it went even ahead, tell me how it is reported, either in mg per dl or millimoles per liter, because conventionally we report the SI units is in millimoles per liter, but conventionally it is done in milligrams per dl. And I think it's good to embrace these tools that are with us, because they really they do a deep search in most of the things. So in summary, this is what is the definition of glycemia. So when we are monitoring glycemia, basically what we're doing is trying to look at the body's energy balance or the metabolic health. And when we talk about metabolic health, when there's dysglycemia, that is fluctuation of glycemia outside the normal, then we tend to get a condition that is called diabetes mellitus, and usually it's a metabolic disorder per se. So just to look at how homeostasis works in terms of glucose, because as we have understood that glucose is key, because it gives us the energy that we require. So we usually have a balance. So at any given time, we have to balance the blood glucose levels. And at fed state, when we start at 9 o'clock, we go 9 o'clock to 9 o'clock. So when you're looking at a screen, just look at the 9 o'clock. So when you eat your food, because when you eat food, your blood glucose rises. And when your blood glucose rises, the balance tips. So it's on the higher end. So what happens? Insulin kicks in, because there's insulin kicks. And once the insulin kicks in, it will take what we call insulin signaling. And insulin usually acts on three principal organs or tissues. So the first one is the liver, the other one is the adipose tissue, and the other one is the muscle tissue. So the reason why this happens is because these tissues are very abundant in insulin receptors. So once the insulin binds to its receptors in the three organs and the adipose tissue, what will happen is that it will increase the uptake of glucose in the muscles and also in the adipose tissue. And also it will increase glycogenesis in the liver and reduce gluconeogenesis. And then that will be able to levelize again back to normal your blood glucose level. So that is a very simplistic way of looking at it, but that is what usually happens. What happens then when your blood glucose goes very low? And here we are looking at night, for example. Not necessarily, it doesn't have to be at night, but just for demonstration is, for example, at night when your blood glucose goes very low, again, the balance will tip to the other side. And what happens is that, again, the pancreas, that is the alpha cells of the pancreas, will produce glucagon. And once glucagon is produced, its target organ is usually the liver. And in the liver, it will instruct the liver to do what we call glycogenolysis and the gluconeogenesis. So those are the two principal mechanisms under when you're going hypo. Those are the two principal mechanisms that will help to boost your blood glucose levels so that the balance is maintained. So in summary, there are two main, and I must underline the word main, hormones that help to maintain a glucose homeostasis in normal physiology. That is the glucagon that kicks in when you're hypoglycemic, and insulin when it kicks in when you are hyperglycemic. So as we all know, diabetes, for example, is a condition that is demonstrated by hyperglycemia, and that's why it is usually looking basically at how insulin is functioning, or how insulin kicks in, and how effective it is to levelize your blood glucose. So since we've talked about diabetes as the main thing that we look at when we're looking at glycemia, so a brief overview on diabetes is that Diabetes is a group of metabolic disorders of the carbohydrate metabolism, which glucose is either both underutilized and overproduced, resulting to hyperglycemia. So hyperglycemia is the denominator in diabetes. And usually it results from defect of insulin secretion or insulin action, as I've mentioned, or sometimes it is both. Either there's not enough insulin being secreted, or the insulin itself in this function in its signaling, it's not able to do its function properly, and then you are unable to get the results that are desired when we look at insulin signaling. And sometimes it is both a secretion and action that are affected. The prevalence is rising and keeps on rising, but based on 2024 data from International Federation of Diabetes, in 2024, it was estimated that the Kenyan prevalence is at 3.4%. But this could probably have a disclaimer, because we know about 45% of people with diabetes are undiagnosed. So probably it could be higher than that because of that aspect of underdiagnosis. When you look at the categorization or the classes, the classification of diabetes, we have four, and the four ones are type 1 diabetes, which accounts for 5 to 10% of all diabetic cases and is usually characterized by autoimmune destruction of the pancreatic beta cells. Then we have type 2, which accounts for about 90 to 95% of all diabetic cases and usually characterized by insulin resistance or insulin deficiency. Then we have other secondary diabetic mellitus, which constitute a very small percentage, and it is associated with certain conditions and pathologies or disorders. And then we have gestational diabetes, which accounts for 1 to 14% of all pregnancies. It happens, actually, it occurs in between 1 to 14% of all pregnancies based on the criteria that is used to diagnose this kind of a decision. And importantly, we need to note that most of the time, gestational diabetes happens in the second trimester or at the end of the second trimester or the beginning of the third trimester. But most recently, and we've classically known the four classes of diabetes, but interestingly, a few days ago, I came across this paper that was published, I think, in January, that talks about type 5 diabetes, redefining pancreatogenic diabetes through molecular imaging and AI-driven evidence. So when I was looking at this paper in the background, they were talking about type 5 diabetes, denoting, and they were saying WHO and ADA classification overlook its complex concurrent endocrine and exocrine features. And I went ahead and looked at the International Federation of Diabetes, and this is what I got. Sorry for that.
Sorry, keep team, we can't hear you.
Yeah, sorry, apologies for that. I got a small distraction. I hope you can hear me now, Nelly?
Yes, I can hear you.
Okay, sorry for that interruption. I got interrupted. So I was talking about type 5 diabetes because we've been seeing about in literature we've been having four classes, but most recently, as you can see, this paper is very recent, published in January. And when I saw this type 5 diabetes, we were discussing with a colleague of mine about type 5 diabetes, and this was a very interesting paper that we saw. Then I went ahead to look at the International International Diabetes Federation, and I realized that actually this is a condition that has previously been mentioned as malnutrition related to diabetes, MDRDM, and it has now been officially recognized as type 5 diabetes. So it is important that we note that now we have another class of diabetes that is associated with malnutrition. And especially it primarily affects people in low and middle income countries where we are, and of course in Southeast Asia and Sub-Saharan Africa. So this is an interesting type of diabetes that we also need to watch out for. So by virtue, diabetes itself does not by virtue, diabetes itself does not cause the disease, okay, does not put you down, but it's usually the complications that you suffer from. So the most of the bulk of the conditions that you suffer, the ailments that you suffer, and what is feared most about diabetes is the complications. And the complications usually come about because of usually uncontrolled diabetes. And we usually look at them in two ways. Okay, there are two major complications of diabetes, and one is the microvascular complication, which usually talk about diabetic retinopathy, diabetic nephropathy, and neuropathy. So usually those are the microvascular complications, and then we have macrovascular complications, which usually is the peripheral artery disease, which usually comes about like the diabetic foots that has led to a lot of amputations. Then we have the heart being affected through the coronary artery disease. And then in the brain, you usually suffer with stroke. I'm sure you've seen people who have been affected by these. But there are other non-classic targets like atherosclerosis, non-alcoholic fatty liver disease, and also pulmonary macrovascular disease. And we also recently look at also on cancer in terms of part of the chronic complications of diabetes. So if you look at these, you can see that just because of hyperglycemia, we can have so many conditions that can come up after that. So this is the reason why it is important for us to really look at the control of glycemia, because that's the question. Why do we need to check on the glycemic control? And it has been noted that complications can be prevented or delayed by optimal glycemic control. So if you're able to maintain your glycemia within the targets, then you are able to delay or prevent the complications that come about with diabetes. And this was very well argumented by two major studies. These were clinical studies that was done. The first one was diabetic control complication trial, the DCCT study that took 10 years between 1983 and 1993. And they were able to show that with intensive control of your blood glucose, you are able to delay the complications of diabetes. And this was also augmented by the UK prospective diabetes studies that followed later after the DCCT. And they were also be able, and they added another aspect of high blood pressure, and they were able to see that if you can intensively control your blood glucose, then you are able to delay the complications that come about. So how then do we monitor glycemic control? So there are two main ways. The first one is by measuring glucose itself or monitoring the glucose itself. And the other one is by use of HbA1c. So there are methods that we use, and in the coming slides, I'm going just to talk about how we measure glucose and the concerns that we need to look about. And then I'll also talk about HbA1c, because the two are the major ways of looking at glycemic control in individuals. So in the next few slides, I'm just going to borrow from this paper that was published in 2023. And this paper was titled Guidelines and Recommendation for Laboratory Analysis in the Diagnosis and Management of Diabetes, because it looks at the recommendation. And this was produced by American Diabetic Association. And yeah, basically it is American Diabetic Association publication. And it talks about the recommendation. And this particular paper is it's an evidence-based paper. And when you're looking at evidence-based paper, they usually rate the recommendation is rated A to C. That means if we rate a recommendation at A, it means it's highly recommended and there's enough evidence and nothing might change in the coming future. And then B is just a recommendation. There's no much evidence. The quality of evidence is not much, and maybe further research might change what we think. And then C is just a recommendation, but there is very low evidence and the quality of evidence, and things might change if. So you will see in the recommendations, once I talk about I will be able to classify the recommendation. But before we go there, let's look at glucose. As we have already mentioned, glucose measurement is a critical investigation in metabolic disease management, especially in diabetes and other inherited disorders. And as we know, glucose can be measured through whole blood, serum, or plasma, but plasma is the recommended one for diagnosis, as we shall see in one of the recommendations. But it is important to note that the WHO, that is the World Health Organization, also accept the measurement of glucose in capillary, either skin puncture or finger stick blood. And the reason why WHO adopted this is because we know there's health disparities across the world. There's parts of this world that are not able to afford a proper analyzer. And the reason for that is
Peter, you are muted. Kindly unmute.
Yeah, as we as we all know, I was talking about that WHO also accepts the measurement of glucose in capillary because across the world, it's not there's variability. There are areas that they are not able to access equipments that can measure plasma glucose, which is recommended for diagnosis. So I think that's why WHO also accepts finger prick or skin puncture for blood glucose levels. So it is important also to know that glucose in our laboratory is exclusively measured by enzymatic methods. There are 3 of them. Either you're going to do glucose oxidase, which is the most common one, or exokinase, which is available but not commonly used. Then we have glucose dehydrogenase. So the 3 of them will be used interchangeably, either in point of care or in the main analyzers in the lab. So usually that's how we measure our glucose. And yeah, so that's how glucose is measured. But let's look at diabetes mellitus screening. And we've started looking now at the recommendation from the paper that I've just shared. And in screening, the recommendation that is there is that screening should be done by 3 parameters: HbA1c, fasting plasma glucose, and 2-hour oral glucose tolerance tests. And these are the ones which are recommended. And these should be repeated at least every 3 years if you find that after screening, this person has an HbA1c of less than 5%, a fasting plasma glucose of less than 5.6%, or a 2-hour plasma glucose of less than 7.8 millimoles per liter. And if you look at the evidence, this is just a recommendation. It might change because it's category B, And the level of evidence that is available is moderate. So that's how we rate recommendations. The second recommendation about screening is glucose should be measured in venous plasma when used for screening of high-risk individuals. You need to note high-risk and venous plasma. So venous plasma is the most recommended, and the category for this recommendation is B, and the evidence is moderate. So that means things might change in the coming future if better research is done. Then this second recommendation is important because we know that when we go to the population, most of the time we use finger prick and we use that to screen. But if you get somebody using a whole blood and it's high, then you need to refer them to probably a mainstream laboratory for them to be able to do whatever they need to do in terms of testing venous blood. The third recommendation is plasma glucose should be measured by an accredited laboratory when used for diagnosis. And this is the level of evidence for this is good practice point. So there's no much, this is usually by consensus or by experts, and that's why they say it should be done in an accredited laboratory. And all of us understand why they're insisting it in an accredited laboratory. When we go to glucose in terms of using it for diagnosis, the recommendation here is that fasting glucose should be measured in venous plasma again when used to establish diagnosis of diabetes. So if you're using whole blood, then you might not be meeting this requirement. And when you are interpreting it, again, you need to know which kind of sample was being used. But again, it's not the only way of diagnosing diabetes. The other criteria of diagnosing diabetes, as we had said, we can use HbA1c, fasting plasma glucose, and 2-hour. And also sometimes when the patient is showing the signs of diabetes and he has a random plasma glucose of more than 11.1%. Just to reiterate that when you are using glucose to diagnose diabetes, the cutoff is 7.0 millimoles per liter, and the recommended sample is usually venous plasma. When we look at the analytical consideration, if we look at the pre-analyticals, the recommendation in this paper talks about blood for fasting plasma glucose analysis should be drawn in the morning after a fasted overnight, at least 8 hours. And the category is B, and the evidence is very low. So this might change, but this is what they recommend. A fasting of 8 hours, that is non-caloric intake for 8 hours, and usually should be done in the morning. We should underline the morning, because sometimes you find somebody comes to your lab and tell you have fasted, it's at maybe noon, and tells you have not eaten for the past 8 hours. So the interpretation of that glucose result will be different. So it's preferably, and in my opinion, I think preferably something before 9 a.m. Would be my personal preference, to do a fasting before 9 a.m. in the morning. But yeah, morning, it depends on how you define a morning. So the second interesting recommendation from this paper is to minimize glycolysis. An effective glycolytic inhibitor such as granulated citrate buffer should be used for collecting the sample. And in the last line on this recommendation, it clearly says tubes with only enolase inhibitors such as sodium fluoride should not be relied on to prevent glycolysis. And the evidence is moderate. And this was very interesting to me, because we all know that the tubes that we use for blood glucose is usually fluoride, but this recommends that we should not rely on sodium fluoride, rather than have a granulated citrate buffer, because that is the best tube that should be used. It was interesting to me, and I will show in the next slide why it was interesting to me to find out of this, because we always know that sodium fluoride is the tube of choice, but now these recommendations are cautionary that we should not rely. And if you are relying on this, then you should do centrifugation within 15 to 30 minutes so that you're able to minimize glycolysis. When you look at the analytical, the recommendation is the performance of your method in laboratory should have an imprecision of less than 2.4%. And in my experience, I think most of the glucose assay in the main analyzer are able to meet these performance specifications. That is imprecision of less than 2.4%, bias of less than 2.1%, and total error of less than 6.1%. And the reason for this is to avoid misclassification of individuals. The goals for, because we know as we know that as we know that the recommendation for this is that we've seen that 7.0 is 7.0 is usually the cutoff. So if you have a very imprecise method, then there are chances that you will misclassify patients. You will misclassify patients in terms of if your method is not performing very well as per the standard. But just to reiterate on why on the citrate tube and the sodium fluoride tube. So I came across, when I wanted to dig deeper into this, I came across this paper that was published in July last year, titled Blood Glucose Measurement Inside and Outside the Laboratory, both Pre-Analytical and Analytical Challenges. I was not able to get this full paper, and I just read through the abstract, and because I didn't have access to the full paper. And they introduced a very interesting tube, which is called citrate buffered sodium fluoride EDTA, which is in bracket FCE tubes, which have been introduced to inhibit glycolysis very effective. And the demonstration they give is that in glycolysis, we know the process of glycolysis. So the new tube that they're introducing, the FCE tube, is able to stop at the very first step. But when you look at sodium fluoride, it's almost at the end. So this is the reason why they are saying you should not rely on fluoride tubes rather than have something that has citrate, a buffered citrate tube. So this is a very interesting discussion that we might have to look into this new tube, especially when we want to become very precise in the diagnostic. And this applies mostly when we are doing our OGTTs. And this is a very interesting thing to look at in the coming days and see how we can advise if in terms of sodium fluoride to avoid misclassification, especially when we are screening for glucose. So when we look at glucose again in terms of the recommendation for monitoring and prognosis, the recommendation is routine measurement for plasma glucose in the laboratory is not recommended as the primary means of monitoring or evaluating therapy in individuals with diabetes. So what does this mean? If a patient has been diagnosed using plasma glucose in the laboratory and it's confirmed that he's diabetic, then the plasma glucose is not recommended for routine checkups for this patient or for routine monitoring. That is, and the class for this recommendation is B, and the evidence is moderate. Then this brings us to the glucose meters. Because we are out of the laboratory now, we have glucose meters, and there are quite a number of glucose meters that are available, and usually we talk of them as point of care. And the first recommendation in using it for diagnosis, it is very clear. Portable glucose meters should not be used in the diagnosis of diabetes, including the gestational diabetes, and the evidence is moderate. But this is interesting because I had mentioned that the WHO accepts, and again, there's a thin line here, because if you say it is not used, again, there are some part of this world that are not able to afford the other method. So WHO gives a window, but this recommendation, like I said, is from the American Diabetic Association, because it's mostly based in America. But it's important to note that they are recommending that it should not be used, because I guess it's because of the standardization and all those things. And in terms of monitoring and prognosis, the frequency of blood monitoring is recommended for all people with diabetes who use intensive insulin regimens. So if a patient is on intensive insulin regimen, they should be using blood glucose monitoring. And blood glucose monitoring changed its name. Previously, if you look at other literature, you'll see them being called SMBG, that is self-monitoring blood glucose, but it changed, the name changed to BGM, to just blood glucose monitoring. And when you see this is synonymous with the glucose meters. And the other recommendation is that the use of BGM is not recommended for people with type 2 diabetes who are being treated with diet or oral agents alone. So if a patient is not under intensive insulin regimen, it is not recommended that he keeps on using the BGM. So because this increases the cost for these patients, and the evidence for this is high. If you see, it's category A and it's very high. So bound to change on this kind of recommendation. But for likewise for recommendation number 2, nothing like change. So the other one, we look at glucose meters in terms of analytical consideration. So the recommendation here is in hospitals and acute care facilities, the point of care testing personnel, including nurses, should use glucose meters that are intended for professional use. And this is general good practice. But it is interesting because most of the glucose meters are not intended for professional use. The market, most of the glucose meters that are available in the market are not for professional. And I think I've come across only 2 glucose meters that have clearly indicated that these can be used for professional use. But again, it's important to know the second recommendation where testing for newborns, the personnel using it should use meters that are intended for use in newborns. Again, this is another big challenge because most of the meters, especially the handheld meters that we have in the market, especially in the Kenyan market, are not able to meet these 2 criteria. It's, I think, only 2 meters that I know of are able to pick these, not unless we go to the real point of care, the ones that we have. But most of these glucose meters that we have are unable to meet these. So it is an important consideration that we need to look at. I know it has cost implications and all those things, but it is important as scientists that we understand that these are the technicalities that we face, especially when we are trying to interpret. And for newborn especially, it is also important to look at the issue of hematocrit values, because newborns usually have very high hematocrit values, and most of the meters are unable to give precise readings when we have high hematocrit values. The other method that is used to monitor is what we call CGMs. CGM stands for continuous glucose monitoring. This is the new way of people who are on intensive use insulin treatment are using. So it's a patch. As you can see, there's a patch here. If you look at the photo, and what it does, it measures your interstitial glucose every 5 to 15 minutes and records those results. And as we might know, interstitial glucose is usually, it correlates very well with blood glucose. And it helps individuals to trend blood glucose over several hours and days. And the current CGMs are usually having a glucose sensor, as you can see, that is inserted into the skin, and there's an adhesive, then there's a transmitter. And in this probe, we usually have a semi-permeable membrane and then a glucose oxidase layer and electrode. So it's more like a glucose meter, but now is implanted into your skin. And then there's always a transmitter, and then you have a receiver that usually sends the data, either a smartphone or a smart gadget or a smartwatch. And if you look at the picture there, some are even linked to an insulin pump, where if it monitors your glucose and it finds that you are going to hyper, then the insulin pump is able to pump a few insulin into your system to regularize the blood. So this is the new way on how diabetes is being managed. I know the cost is still exorbitant, but it's something that it's important for us to understand that it is already in the market, and people are adopting this, especially for those who are in intensive glucose monitoring. What is the recommendation on non-invasive glucose sensing? We all know that nowadays we have smartwatches that if you look at it, it can be able to measure your blood glucose. And the recommendation here is that overall, the non-invasive glucose measurement system cannot be recommended as a replacement for BGMs or CGMs technology at this time. So the evidence is very low, but current recommendation is that they cannot replace either blood glucose meter or continuous glucose monitoring technology. So it's not recommended if somebody asks, but I have a smartwatch, I'm monitoring my blood glucose using that. So let's just dive in a little bit on HbA1c. So we all know that glycation usually refers to non-enzymatic attachment of glucose to available amino acids. And HbA1c glycation generally reflects on the exposure of protein to glycemia, and that's why it's used. And when we talk about 3 months, it's because it's the exposure of the red blood cell, because we know the lifetime of the red blood cells is approximately 3 months. So we know that when we measure your HbA1c, the exposure has been more or less that 3 months. And the terms that have been used are glycated hemoglobin, glycohemoglobin, glycosylated hemoglobin, glucosylated hemoglobin, HbA1a, HbA1c, and A1c. So all these terms are used, but it is important to know that these terms are not interchangeable, because some are biochemistry in nature, because when you say glycosylated and glycation are two different biochemical processes. But the acceptable term is usually glycated hemoglobin. That is the accepted term. And HbA1c is the specific glycated species that is modified by glucose on the N-terminal. And when you look at the biochemistry on itself, you will see that glucose gets attached to the HB, and then there's a shift-base formation, then there's a slow process, which is usually called the Amadori rearrangement, and then you get a ketoamine. And this ketoamine is what we call HbA1c. And if you classify HB in general, human adults, 97% will be HbA, which has 2 alpha chains and 2 beta chains. And out of this 94 is HbA0, which is glycated. And then we have HbA1, which is glycated. And under the glycated, we have 3 of them. We have HbA1a, HbA1b, and HbA1c. HbA1c is the major component, making 5%, and then the other 2 make about 1%, so that the entire HbA is like that. So when we are measuring, we are usually concerned with the HbA1c, but again, some methods are not very selective to distinguish between HbA1a, HbA1b, and HbA1c. And that brings us to the testing methodologies. So there are 2 main testing methodologies for HbA1c. There are those which have a separation, and we have 3: HPLC, ion exchange, capillary electrophoresis, and affinity chromatography. So those are their basic principle is separation, either by charge difference or by affinity. So we have the 3 methods, but again, we have other applications that basic principle is chemical, that can either be an immunoassay or an enzymatic assay. So out of these 5 methods, we have a lot of methods that have been developed by manufacturers to measure HbA1c. And most of them currently are standardized to the IFCC. So any that you find are usually traceable to IFCC standardization, most of them. But if they are not, you can always ask your supplier to give you that information, or the manufacturer of that kit. So what are the recommendations? So the first recommendation on screening and diagnosis is that HbA1c can be used to screen for diabetes and pre-diabetes based on the values. And it is important to underline that when you're using any HbA1c, you should use an NGSP certified method. In terms of monitoring, it is recommended that HbA1c is done routinely, usually every 3 months until you meet your targets. And after that, I think you do every 6 months, but this will depend on how your glucose control is. When you look at the analytical consideration for HbA1c, in terms of traceability, the recommendation is that laboratory should only use HbA1c assay methods that are certified by the NGSP as traceable to the DCCT reference and also traceable to the IFCC reference method, and this is good practice. It is also recommended that laboratory should participate in accuracy-based proficiency testing, that's an EQA, that uses fresh whole blood samples. This is another challenge currently in our market because we are not able to get fresh whole blood samples. But the reason why this is there is because of commutability, because we want to use a native sample that can react the same way a patient sample would be. So the recommendation is if we are able to get fresh whole blood samples, it would be the best for us to see the performance of our HbA1c. And in terms of analytical performance goals, we should have a method that has a CV of less than 1.5%. This is a very strict performance criteria. Less than 1.5% CV for intra-laboratory assays is a very good method, you ask me. And the total inter-laboratory assay of less than 2.5%, and you should use at least 2 controls with different HbA. And I think they also recommend that they should not be measurable bias for this. So I think the analytical performance goals for HbA1c are very stringent. And if we are able to meet these, then I think we should be able to manage our glycemia very well in our patients very well. So I'm not sure how data looks like, but I know we need to really look at the performance specifications for our HbA1c method. So next time you're looking at performance specification or you are getting a new tool for HbA1c, it is important to underline that the CV when you are verifying should be less than 1.5% for that method. So in terms of clinical applications, there's a recommendation that HbA1c should be reported in percentage or in millimoles per mole. So usually percentage is DCCT and millimoles is usually IFCC units, and they are used interchangeably. There are labs that will report both of them, but majority of our clinicians, I think, prefer using the percentage way from my setting where I work. It is important to note that HbA1c may also be estimated as estimated average glucose, that is and there's a formula that you can use to do this because it helps you to correlate but sometimes this is avoided most of the time because it causes confusion, because most of the time when you look at the percentage reporting, people translate it directly, like if I have a 6% HbA1c, then my glucose has been averaging at around 6 millimoles per liter, but that usually is not the case. And there's a formula for you to calculate an estimated average glucose using HbA1c, which I'm not able to share here, but it's available in literature. So there are also other biomarkers that are available. Fructosamine, glycated albumin, and 1,5-anhydroglutathione are available, especially this 1,5-anhydroglutathione is already approved in the US. Glycated albumin is better sometimes when we have because HbA1c also has its own population which you can't use. You can use glycated albumin or fructosamine, but I know what has been fronted more is glycated albumin, and it gives you an average of 2 to 3 weeks. Again, this is based on the half-life of albumin in circulation. So in conclusion, the laboratory plays a key role in monitoring glycemia, and most of the glycemic monitoring methods are standardized if you look at it critically. And glycemic monitoring methods have limitations in terms either assays or physiologic, and should be considered when we are interpreting results. Anytime you are interpreting any result, you should always underline the limitations that might have happened in that assay or physiologically, and then you're able to do proper interpretation. And clinical chemists, or by extension, laboratory professional, play a very valuable role in choosing an appropriate method for monitoring glycemia in our patients. So thank you. And before I end, I would just like to invite the fraternity of LMSK just to inform you that as Clinical Chemist Association of Kenya, we are partnering with the African Federation of Clinical Chemistry and the IFCC, and we are organizing the 8th AFCC Regional Congress that will be coming up in 16th and 17th of July this year. And you can visit that website to just see what is upcoming. So we expect to have 8 symposia during this Congress, and the call for abstract is open. The abstracts call ends on 31st of this month. So if you have an abstract, I really encourage you to submit your abstract. We should be able to inform you by May 1st if your abstract has been accepted. And I hope to see you in July in this interesting Congress that we are trying to organize. So thank you so much. I will bring it back to you, Nelly, for moderation of the next session. Thank you so much. Asante.
Thank you. Thank you so much, Peter, for that elaborate presentation. I like it that you mixing real lab results and research that has been done in the field. That's great. That's great of you. Thank you so much. Members, we really appreciate Peter, and we appreciate all of you for being here. I had requested you to write your questions and your contributions on the chat list. This is the time that I would want us to go through that so that Peter can have some time to react to them. Thank you so much, Dorcas, Josephat, and Charity. I see that. And Peter, we really appreciate. And Dorcas says it's an excellent presentation. I do agree with her. Thank you for that good work. And thank you for the invitation. Members, get a screenshot of that and save it somewhere and send your abstract and your proposal so that you are part of this presentation happening on July from 16th to 17th. So, Peter, there are some few concerns here that I would want you to react to. And I will want to start with Charity Akwea. I think from your presentation, she picked something that she's wondering and asking. Is diabetes mellitus type 5? Do we have diabetes mellitus type 5? That is what Charity is asking. Peter, back to you.
Yeah, thank you. Thank you, Charity, for that question. Like I said, it is the new. I think if you look, and I'm just going to, I would. It's a new, and it was recognized actually January 2025 by International Diabetic Federation. So it's one of the interesting things that you're going to look at in the coming days. So it's still very new. I think it's the first time even me I'm looking at it, and I've just gone back to this paper. If you have time, you can take screenshot of this, go read on it, and also you can visit the International Diabetes Federation. They have more information about this type of. So it's a very new one, I guess, to most of us, and yeah, it is interesting so that we can see what is coming up in the coming days. Thanks. Thank you.
Thank you, Peter. Charity, there goes your answer. Next concern, and next concern, and Josephat Meme starts by praising Peter by saying that this was a superior delivery and kudos to Peter. His question is, you're welcome. His question is, can you please give an example of the glucose meters recommended for professional use? Can you please give an example of glucose meter recommended for professional use? Back to you, Peter.
Thank you. Thank you. I think, thank you for that concern. And unfortunately, I'm not able to give it in this public forum because of proprietary issues and promotional issues, because this is a purely learning environment. But I guess we can have this chat outside this. Please let me not share that in this forum, but it's something that we can discuss outside this. Thank you. Back to you, Nelly. Apologies, I can't give the brand in this forum, for example. You all understand why I can't do that. Thank you.
Well noted, Peter. Well noted.
Yeah.
Kindly, Josephat, you can see Peter on the sides. Dorcas says it's an excellent presentation. Wilfred Gatua also says, good presentation, sir. That's to you. Thanks to you, Peter.
Thank you, Dr.
Abel Nduki says, excellent presentation, Dr. Peter. Ismail Masitsa, well articulated, Doc. Blessings. And then we get to Esther Kinyua, who says, wow, we have a gadget mounted on the body to measure and release insulin when necessary. Wonderful technology there. You can react to that?
Yeah, I think it's interesting, and this is already being used, and I know it's still not actually, if you look at recommendation nowadays, they compare your HbA1c and CGM, especially in developed countries, and this is an implant that you'll get in your skin. It's quite expensive. It lasts for about I think on average 7 days, and then you keep replenishing, because it can only do a maximum number of glucose, and then it will chart for you, and it alerts you when you're going hypo, when you're going hyper through your smartwatch. So it's a very interesting technology that is happening. And for those who have advanced, there's the pump where you can be able to control. So these are interesting things that are happening. They're already being used. These are FDA approved. And yeah, they are available. You can read more on it. It's important for you to familiarize yourself with this, but they're actually available in this market if you look for them. But I know they are still a bit costly, but hopefully in the coming future, they'll be a bit affordable. Yeah, thank you.
Thank you, Peter. Paul Sairo says, great one, Peter. So which are the professional recommended glucose meters? I think, Peter, you can just...
Again, yeah, sure. Thank you, Paul. Paul, I think Paul is my classmate. Thanks, Paul, for joining this. So I think we'll have a chat on the side so that we can have that discussion, because, yeah, I can't do promotional at this time or give a brand, because this is purely an educational webinar. Thank you.
Thank you. Thank you, Peter. And Gichuti says a good presentation. Unita Atieno, very insightful presentation. Thank you. Thank you, Peter. Robert Juma. Robert Juma has a question here. The CGM is a good one. Is it able to pick this Somogy phenomenon? Question from Robert Juma there.
Yeah, I think the Somogy, you know, the Somogy is when in the morning when your glucose dips. Yes, it does. The CGM is able to, and that's why it is important, so that you don't go to hypo and it alerts you, and that's why it's coming in very strongly. So it's able to, because it modulates across. So yes, it's able to do that. It's able to do that. I hope I got your question well. I really hope I have answered it.
Thank you, Peter. Robert, I hope you're still here. So if you're okay with the answer, kindly just put a reaction, or if you need some more explanation, you can add up to your question down there. So we move on to Magdalene Duku, and Magdalene says, good presentation. And then Amos Kamau Njoroge. Amos Kamau starts by thanking you, Peter, for the presentation, and then he has 2 questions. So I'll read both of them, and then I'll give you time to react to them. So A, kindly elaborate a little more how diabetes mellitus type 5 comes about if it's nutritional related. And then part B of Amos's question, he asked, what's the clinical utility of HOMA IR for glycemic monitoring? What's the clinical utility of HOMA IR for glycemic monitoring?
I think, thank you so much, Amos, for those very good questions. So if I may handle your first question about type 5 diabetes, how it comes about. What I've read briefly, because it's still also very new to me, I've not really read it, but it is associated with malnutrition. And the most interesting part is that apart from what we know that if you have high BMI, then you have, so they are saying the impact is malnutrition, exposure to malnutrition for a very long time, then it creates this one. And most of it, you will find they have the classical signs of diabetes, but now if you look at their BMI is very low, they have very low body weights. But again, this is still very new. It's something that we also looking at. It's actually very new to me. I'm still trying to figure it out, and probably in the coming days, we will be able to talk more about it. In your second question, you ask about the clinical utility of HOMA IR for glycemic monitoring. So HOMA IR is not used for glycemic monitoring. HOMA IR is usually used when we want to see whether you are producing enough insulin, especially at the diagnostic stage, and usually in some condition is now when we apply HOMA IR because it's related to insulin resistance. We want to see if you are able to produce enough insulin, and that's when we are trying to establish the diagnosis of whatever it's ailing you. So it's not used for clinically it's not utilized for glycemic monitoring. The only tools that I've shared in this presentation probably are the ones that are used for unless we have any other evidence that will come up. But at the current way, I know there's others that I've not mentioned in my talk, but the current one, the most appropriate in our setting, is what I've been able to capture. But just to say, HOMA IR is not used for glycemic monitoring. I hope, Amos, have been able to respond to you appropriately. Yeah, but yeah, that's my take on that. Thank you.
Thank you, Peter. We continue with appreciation here. Joseph Meme says, well understood, Peter, asante. And then we have Kevin Dare. Kevin Dare has a question, and he asks, many patients visit hospitals to take anti-diabetic drugs. Is it advisable because all these drugs don't treat?
I think it's not within my scope to say if they don't treat or they treat, because that will depend on how they are being managed. But our role as the scientists in the laboratory is to ensure that when we have this patient and we are asked to monitor their glucose, we are able to give the value so that when they are managing their glucose, they are meeting their targets. The methods that we are using in the laboratory is helping them to achieve those targets, because if our imprecision of our HbA1c, for example, is not that good, then we are not helping these patients to meet their targets, and they will keep on being adjusted with these drugs, and probably we might not be seeing the outcomes. So the main underlying factor is, as we in the lab, we should look at our methods, and when we are doing this interpretation, we should always remember that our methods sometimes have limitations, and we also need to consider them when we are doing these interpretations. Thank you.
Thank you. Thank you, Peter. I would want to go to Joseph Wafula. And Joseph says, presentation has been excellent. But I would like to ask why some patients, I'm not getting that, why some patients with their glucose tested, when their glucose is tested is high, and when insulin used doesn't reduce what could be the reason for this and what should be done. Let me just try and rephrase this, and I hope this is what Joseph meant to say. Why do some patients, when their glucose is tested, it's high, and when they use insulin, it doesn't reduce? What could be the reason for this? Peter, maybe you can react to that.
Yeah, because insulin is usually a hormone and it depends on insulin signaling. So it could be an insulin receptor issue, but that is very clinical. We can't really say, but that would be a scientific way of just trying to say why the insulin might not be working. Because as we know, insulin is a hormone. It works on insulin signaling. So if your receptor is not very well, or your cells are not responding very well to the insulin, because the link between the insulin, its function is usually through the insulin receptor. So if there's a defect in that relationship of insulin recognition to its receptor, then it wouldn't work, basically. So that's the best scientific explanation that we can give. But your questions lies more to a very clinical side of things, which I might not be in a position to properly elaborate on it, but I hope that sheds some light on your question. Thank you.
Thank you, Peter. Stella Mageto asks, which is the best blood sample for measuring blood glucose?
The best one is usually fasting plasma glucose as recommended, and the analysis should be done as in the shortest time possible. So it is fasting plasma glucose, not serum, but fasting plasma glucose. Thank you.
Well noted. Deborah says this was a good presentation. And Dhoni, job well done, Peter. And then we have Josephat Meme. Oh, okay. Josephat Meme was just reacting to the question that he had asked you about there. And he says, thanks, Peter, for your vigilance and caution about the type glucometer to be used. Yeah.
Yeah, thank you, Josephat, for understanding. Thank you.
Wilfred Gatua ask if they can make a comment. Wilfred, do you want to talk so that I allow you? You can raise your hand if you want to talk, then I will unmute you and you can talk. So as Wilfred does that, Elika Nangili asks, why is that a patient condition worsen more when the glucose level is low as compared to when it is high? Why does a patient condition worsen more when the glucose level is low as compared to when it's high? Peter, back to you.
Yeah, I thank you for that very important question. Glycemia is a life-threatening condition because your body basically requires glucose for every function because you need energy, especially look at the brain. The brain cannot function without glucose, and it's the only way it can get its cells to function because it's only glucose that can go through to the brain. So the reason why the patient worsens is because the body actually requires glucose. For hyperglycemia, of course, the only thing that you will suffer from is the complications, but you will still manage. But that is the reason, because glucose is basic. It's more like required for life. And if you lack this, just worsen. When we always advise that when you do a blood glucose for somebody and it's below 3, just get something for him to eat, because the next meeting that patient will collapse, and unfortunately we might lose that patient. So I always advise people that any hypoglycemic patient should never you should never leave your side unless you stabilize that blood. It's because you just need to give him something sugary to take, and then they'll be able to pick it up. So that is the reason, because the body depends on glucose basically to function. Thank you.
Thank you, Peter. Benson here says that the the presentation is quite excellent. He's appreciating you for that. And then Leonard Bosco Otieno says that a degree of insulin resistance is the reason for poor response to insulin administration, glucose not reducing. So Leonard there with his inputs on the discussion. Thank you, Leonard. Wilfred Gatua says yes. Okay, we agree with you, Wilfred. And then Ibrahim Belli Tari says, very interesting and clear presentation. Thank you so much, Peter. Peter received the appreciation from the members today.
Yeah,
We really appreciate.
Thank you so much.
Thank you.
Yeah.
Thank you. Then I would want to go to a member here by the name Joshua Shoka. Joshua Shoka asks, how do we get CPD for clinical officers who join this webinar? So Joshua, I want to take this one and inform you that the points are uploaded on the automatically uploaded once you register and you give the right information, your member number, the points will be uploaded. Kindly check your account within 24 hours. The points will have been uploaded. And to Irene Vuremi, back to you, Peter, with the questions. So Irene Vuremi says, you mentioned about a new anticoagulant besides the usual sodium fluoride for blood sampling used for glucose test. Are they currently available? And the other part of his question is, why are they better than fluoride vacutainers? To you, Peter.
Yeah, I think when I was talking about this recommendation, I've just taken you back to that interesting paper. The challenge is I've not been able to get the full paper. I've just read the abstract, and part of the abstract is this figure that they look at, and the new container of tube that they are talking about is called citrate buffered sodium fluoride ETTA, or FCE. And they say it is available. I don't know in our market if it's available. Maybe we can ask the distributors within our market if they can be able to source for these. And the reason why they say it's better than fluoride is, if you see in your screen, when we look at glycolysis, we know what happens through to pyruvate from glucose. So the new tube is able to stop immediately. So there's no glucose that starts the process. But when you look at fluoride, it comes to almost the tail end of glycolysis. So chances are that when you are measuring using sodium fluoride, there are some glucose that might have been lost before you measure. But for this, it's just immediate. That proceeds. So I think that answers your question, hopefully. Thanks.
Thank you. Thank you, Peter. Irene, I hope you are well answered. Thank you, members, for your input. Thank you so much for the questions that have been so interactive, and the input and your observations. Thank you. And even for joining the webinar this evening. And I would like to take this opportunity also to thank Peter for preparing and articulating the subject so well, and good presentation, and even inviting us to a congress, an upcoming congress. Thank you so much, Peter. I also want to take this opportunity to thank LMSK for creating these the webinar and creating time for us to be here. Sorry, I can see some hands that have been raised. I would like to give these people an opportunity. I can't see who they are. Okay, sorry. There's Rafael Kaplich and Wilfred Gatau. I would like to give you 2 minutes each, kindly, to express your views. So I will start with Rafael. Rafael, you can unmute.
Sorry, thank you for that. This is a very interactive session, very precise to the point, and really learned a lot. I would wish to kindly ask for my brother's number. I have some more issues to address. I have I think around 2 family patients on the insulin. I would think I would need more of an interaction with him for more information. Am
Thank you.
I?
Yes, sure. I think that's okay, and probably I will share. Can share my contacts. Okay, I'll yeah, sure.
Can I give my, can I just shout my number so that you can take note on that?
Okay,
And you
sure.
can say
Sure.
chat. Yes.
07
0722
0722
49
49
82
82
44.
44. For sure, I'll get
Yes,
back to you.
I'll appreciate.
No pressure. Thanks.
Thanks.
Thank you. Thank you, Kaplich. Thank you. Frida Wilfred Gatau, kindly you can unmute.
Hello, good evening.
Good evening,
Daktari.
Wilfred.
Oh, thank you. Thank you very much, Peter. That was a wonderful presentation on glucose monitoring using the point of care testing, the glucometer. And I like your passion about ensuring that our patients are getting the right measurements for glucose so that they can get the right management. I think I have been observing you and you are very passionate about this point of care testing and especially the sugar. But I just want to make some comment that, of course, sugar has been delegated to the nurses. The measurement of sugar largely is being done by nurses and the doctors in the wards, in their offices, and even patients are carrying their own glucometers in their pocket and they monitor their sugars at home. So the testing, the blood sugar testing has really shifted from the laboratory to the point of care, and we cannot deny that. So the only thing we can do as a laboratory, and I know people have been asking which is the right glucometer to use, and I like your answer that you cannot really mention the name of a blood because that is be counterproductive. But again, as a laboratory, even as we give this glucometer to the nurses and to the doctors, remember we are the one who are supposed to validate and to verify the devices that are going to be used in the hospital. So when you are doing the technical evaluation, you must make sure that the glucometer that is passing is the right one. That means that you can even, when you do technical evaluation, you can even do what we call the plotting so that you compare the reading from the glucometer and the reading from the conventional method that we use, the long method using the laboratory equipment. So that at the end of it all, you get a device that gives more or less the same readings as from the conventional laboratory. So my point is that even as we give these glucometers to the clinical area, remember we are the custodian of all the devices. Any device that measures any sample in the hospital falls under the hands of the laboratory people. And that should be very, very important. And I think the other thing I wanted you to comment on is the IQC, because we have given these glucometers to the wards. So how do we ensure that IQCs are done? And more importantly, the EQA, because the EQA has been a challenge for blood glucose monitoring because of the various methodologies that are being used by various meters. You realize the meters are so many. Sometimes to get an EQA is also a challenge. How do we navigate this? And especially now that even ISO is coming up with that particular requirement of POCT, that how do we monitor the quality of these devices and the quality of the result that we are getting? I think that, Peter, you can be able to comment in a very brief manner. I know that time is rushing. And then the other thing I wanted to comment is about the HbA1c and the methodologies being used. I know you have mentioned those particular methodologies, especially the one we are using, the chemical whatever method. But it's good to note that the gold standard for measuring HbA1c currently is chromatography. I think that's a very, very important point to note. And the gold standard is very important for measuring HbA1c. Thank you very much. Back to you. Back to you, the moderator. Thank you.
Thank you, Dr. Gatua. I think it's a very interesting thing because when we talk about the shift of our standard now, talking about I know IQC and EQA is still a big challenge because it's multiple devices, multiple operators, and when we try to get down to but I think it's all about regulations because in our country, it's not well regulated, I must say. But if you go in the US, the FDA itself has classified the POCT testing into those that are complex and non-complex and what requires. So there are requirements. So the best approach that we are looking at in terms of fulfilling this requirement is that every institution should have a point of care multidisciplinary committee that will involve all these other stakeholders. And we have a candid discussion regarding on how we are going to manage all these meters across. For EQA, I know there are programs that are able to provide EQA, but the challenge would be how do you enroll, for example, in the institution, because I know the institution that we work and you also work for, you might have even upwards of 100 meters outside your scope. So how do you enroll 100 meters, for example, into an EQA program? So it's still a very tight space to navigate, but I think when we sit down as professional and as point of care committees, we should be able to see how best can we achieve that. But for the availability of EQA material, I know it's available. The challenge is how do we enroll them? So I know it's still a very big conversation that we need to have in the coming days. And thank you for mentioning that the gold standards is affinity chromatography. But because of cost, again, we try to look at the other methods which are accessible to the IFCC standard. So thank you for that. Asante sana. Back to you, Nelly.
Thank you, Peter. Thank you for taking your time to react and to answer to those questions so professionally. We really appreciate you. Thank you. And Leonard gives, Leonard Bosco Otieno says, enroll one, use it for an intra-analyzer comparison. So thank you. I would want again to reiterate that we've really enjoyed the presentation. It was clear and interactive, and we've learned a lot. Peter, thank you so much. Members, thank you so much for joining up. Thank you for coming and coming to learn. Thank you so much. And LMSK, I would want to take this opportunity again to just appreciate you for organizing this webinar. So members, I would want to bring this to a close by telling you thank you. We plan to meet again next week, Monday, for more interactive learning sessions. Have a good evening.